We'll start the next session. I'd like to invite Dr. Prabir Chatterjee to moderate the session on government health expenditure and equity in health by Mr. Ravi Duggal.
Yeah, Ravi, you can take the stage. Right. So we have I think the hardcore public health people in here. We've got a few more people coming in. Please do come in. Let's have a slightly bigger audience for the. Right. So Ravi Duggal is an old friend. So I'm not going to go directly into the CV he's presented. You can find it on. And he's been working for years and years and years on health economics, basically. He worked with the Center for Inquiry into Health and Allied Themes. And he has worked with multiple organizations over the years with SWISAID. And he's been into budget analysis. So he's one of the experts on budget analysis. He's also one of the very early researchers. When a compendium was made in the middle 80s, of all the health economic studies that existed in India at that time, he was one of the people who was represented, because at that time, health economics practically did not exist in India. So I think that's where we'll start. He's done a lot of work on out-of-pocket expenditure, a topic very close to our hearts. In fact, my thesis was also supposed to be on that topic. And I leave it to Ravi to explain the topic to us. Over to you, Ravi.
Okay. Thanks, Prabir. Yeah, I'm supposed to talk about government budgets and to look at the dimensions of where equity or inequity is found through budgetary investments in healthcare sector. Okay, a little bit of history. I think it's important to put in place the context of how the political economy of health in India has evolved. You know, we inherited a status model from the colonial era, and even the Bhore Committee, which was just prior to independence, which recommended a national health system model for the country, even that talked about a very statist model. Unfortunately, that never happened in India. It didn't get implemented. Probably NHS learned more from that and implemented it in the UK. And only two countries from the Indian subcontinent actually implemented this, the Bhore Committee report. One was Sri Lanka and the other was Burma, which is now called Myanmar. So they learned from that, and the rest of the Indian subcontinent did not even look at that. And over the years, our entire process of investment in healthcare has been determined by the Planning Commission. Okay, and because the Planning Commission got very little resources, health and education were probably the most neglected sectors, and it was largely the larger industrial and agricultural economy which got a very large chunk of the planned resources which we have. There's only one exception in this country where the planned resources for the social sectors was very huge through the 50s and 60s and 70s, and that was Kerala. If you look at the Kerala budgets from the 50s and 60s to the 70s, you'll find that 50% of their budget, the development budget, went to the to health and education taken together. Okay, so that was a huge investment. That is why Kerala's health outcomes are probably as good as any developed country, and they reached that level somewhere in the mid 70s. I mean, you could compare Kerala with any developed country. And on the other hand, the government allowed an unregulated growth of the private health sector. And of course, the state's healthcare was free through tax funds. And the private sector initially was largely of what you call petty providers. Basically, it was in outpatient care where the private sector was dominant, right through the 50s, 60s, 70s, or even in the colonial period. But in the hospital sector, it was largely the government which was there. This whole thing changed in the 70s when there was a higher priority given to specialty education, postgraduate education in medicine, whereby you had many more outturns of postgraduates, but then they were not interested in general practice. So that is the time when we started setting up a whole lot of small nursing homes and in the private sector. And then later on, much larger hospitals also emerged. And then, of course, now we know since the 90s, I mean, the huge corporate investments that go into the health sector. The private sector started evolving a bit later. Okay, so well, as I said earlier, 5-year plans was the whole process through which health investments were happening. We did not really adhere to the board committee recommendations, which talked about developing a national health system. And but post Alma Ata, we did see some kind of push towards trying to reach that health for all by 2080 target. And that process began somewhere in the mid 80s, 83, 84, when in the sixth plan, the concept of minimum needs program was introduced. I think that was a very revolutionary program, not only for health, but for various other kind of services, especially in rural India. And that the idea was to bring rural India into some sort of comparability with the urban sector in developing all the indicators of development to strengthen in the rural areas. So by 1987, we had actually reached a peak of spending on healthcare of 1.6% of GDP. Now, this is the highest ever that we have reached. Even today, we are down to 1.2%, the latest year. But that is during the 80s, we were around 0.9% of GDP. And during those 3-4 years of intense investment in building the rural infrastructure, that is when this whole concept of 1 PHC per 30,000 population was evolved, or for 20,000 population in tribal areas and hill areas. So that was a time when this happened, and it happened very rapidly. In 3-4 years, most of India had actually met those targets. But unfortunately, it was only construction of PHCs which happened, and we could not find the human resources to work in those primary health centers. It is not that we were not producing enough doctors, but enough doctors were not coming to the public health system. We were producing for the world market, and our doctors, very high number of doctors were migrating to the West or to the Middle East and other countries like Australia and so on. Something on an average of 5,000 to 6,000 doctors every year leave this country. So with the rapid growth of medical education and also then in much later you have health insurance coming in, the private sector was growing very rapidly, especially after the structural adjustment. When the Indian economy went into a crisis in 1990, I mean, that was a time when the whole economy was globally exposed through globalization and privatization, which was what the World Bank was pushing the country to adopt. So our Manmohan Singh becoming the finance minister and under Narasimha Rao, we really pushed very hard on reforming the Indian economy and moving it towards a kind of a globalized economy where global markets started affecting our development process. So we went in that direction. So if you look at the current political economy of health, it's very important to understand that, because if you want to look at inequities within the healthcare system, especially of financing the system, we have a tax finance system which the government provides certain resources, which I said is today around 1.2% of GDP, and roughly you can say about 1,800 rupees per capita. So it's a very small amount of investment that the government is making on healthcare for the common citizens of this country. And therefore, you have a very large and evolving private sector in this country, and therefore out-of-pocket expenditure or insurance payments are increasing very rapidly. In fact, the insurance sector is growing at a compounded annual growth rate of 25 to 30% over the last decade. So that's the kind of growth that you see. And a lot of that is fueled by public resources because governments are buying insurance for the PMJAY scheme or for other state schemes of similar kind. Then, of course, we do have social insurance. So there is this 9 to 10% of the workforce in this country, which you could say is the privileged class. They're government employees, they are employees in the organized sector who get benefits through the central government health scheme or the ESIC, the Employee State Insurance Scheme, or other welfare boards are there for different class of workers, the armed forces, the railways, and so on. So this is a class about 9 to 10% of the workforce, and roughly about 12 to 13% of the population actually, you can say, get assured healthcare, or where right to health has been in some sense realized. Because even after they retire, they get free healthcare. But if somebody who's not worked in the organized sector or has not worked in government, once they retire, I mean, nobody thinks about them at all, and they can't afford to buy health insurance because it's very expensive. For a person like me who's 66 years old, if I need to buy health insurance for 5 lakhs cover, which the PMJAY, for example, gives, the insurance company tells me I have to pay 50,000 premium for myself and my spouse. So, I mean, where do I afford that? I'm not what I call, I'm not a sarkari damad. I don't get pension. And so where will I raise the resources for doing that? The presentation disappeared. Okay, so not moving. Yeah. Okay, so we have public health services. I mean, you all know about this. I will not get into that because of time. As I said, we are spending about 2,000 rupees per capita, or 1.18% of GDP in 2022-23. And in rupee terms, we are spending 2,80,000 crores. This is the health budget of all state governments and the central government put together, including local bodies and so on. So this is what public resources go towards the health sector in this country. And these are some examples of top 5 and bottom 5 states. So interestingly, you see that there's some of these smaller states which are spending a lot of money. Sikkim, Mizoram, Jammu, Kashmir, Haryana, Meghalaya, they are the top spenders. And these are the states which have very good health indicators also. They have good health outcomes and so on. And can anybody tell me why this is happening? Why are these 5 states at the top? Denominators are small, but I think most importantly, these states do not have a private sector of any significance. You see that, when you do not have a private sector, the government is forced to provide better healthcare or to invest much more. So these states are already investing a lot. Sikkim 5,575 per capita, Mizoram 4,300, etc. And Maharashtra, which is supposed to be the most developed state, is in the bottom 5. Okay, because it has the largest private sector, along with Karnataka and Tamil Nadu, and now even Kerala has a very large private health sector. So this is the situation that you see across the country. And the top 5 states are states which actually provide reasonably good healthcare. They're strong primary healthcare systems. If you go to a state like Mizoram, I mean, I've done a study of Mizoram about 2 decades ago, and we find that at that point of time in Mizoram, for a population of 7,000, there was one primary health center, and that primary health center had 30 beds, not 5 or 6 beds, which is mandated by policy. So and had 2 to 3 doctors also. And all the PHCs I visited, there were at that time, I think 30 PHCs in Mizoram. I visited all those 30 PHCs, and we were doing a study actually on abortion, and that's a separate story. But all they had 80 to 90% bed occupancy. All deliveries were being conducted there, and so on. So, and the government was spending a lot of money. I mean, in a state like Mizoram. Okay, over the years, this is what the union government has been spending in the last 7-8 years. This is the kind of thing, and as part of that, NHM is a major program. So NHM is a grant which is given to states. Okay, so that's a major chunk of the total union government's commitment to healthcare. And apart, the balance is actually funding of the different central government hospitals like AIIMS, Delhi, and Safdarjung, and so on. So, or the National Institute of Mental Health in Bangalore. So many of these central institutions are the balance. That the rest is NHM, and you can see that there is some sort of a declining trend also in terms of for NHM also, the resources which the central government is contributing. They want the states to contribute much more. In fact, this government is trying to kill NHM, and it's already kind of half one leg in the grave, but they want to completely finish off that because it's a legacy of the earlier government. And this is the total public health expenditure, the center and states taken together. So state health expenditure, including central grants, is this is in rupees billion. If you remove the decimal, it becomes crores. And so you can see, if you look at some of the ratios, you can clearly see that there's not been much kind of positive changes in terms of resources being invested in healthcare. And we are constant around 1% of GDP that is being devoted to the health sector. Okay, then we have the private health sector. Since Prabir spoke about out-of-pocket payments, and we are one of the countries which has the highest out-of-pocket burden globally. Probably we are from the bottom. We are in the first bottom 10 in terms of the proportion of government government investment in healthcare in the country on a per capita basis. So we are really not doing that well globally. The private sector has they have individual GPs and consultant clinics. You have a wide range of quacks also practicing healthcare, and people of different systems of medicine, of course, are there. And then nursing homes, maternity homes, now corporate hospitals. Incidentally, I mean, diagnostic centers now become an independent business. I mean, you can get diagnostic services at home without any clinical intervention. I mean, they just approach you directly through their marketing practices, and they're really minting money. And COVID was a period where they actually really kind of made huge profits. So diagnostic centers have become independent. I mean, not only laboratories, but even diagnostic services like MRI, CT scans, etc. Incidentally, in the morning, there was a reference to the number of MRIs, etc. In 2010, I did a count of the number of MRIs in London and Mumbai. Okay, there are two cities with similar populations, with a high middle class populations. And in London, at that point, there were some 26 CT scans and MRIs put together. Can anybody tell me how many were there in Mumbai? 360. Okay. Now, is Mumbai such a sick city, getting these kind of serious ailments which require an MRI intervention? No, because healthcare in India is supply-induced demand. Okay, it is the supply is created, and then not by demand but by the supply side. Okay, so it becomes it's a dhanda, it's a trade. It's no longer a profession, healthcare in India, because of the huge private sector that we have. And in UK, it is NHS, which is an organized healthcare system. So they they know how many MRIs they need. Okay. In fact, they may be short of MRIs, but not by too much. Okay, because there are long waiting lists and so on. But Mumbai has 360 at that, but probably now it's close to 1,000. So these are 10 figures which I was quoting. So this is the kind of environment in which our health system is kind of has evolved, and a very strong unregulated private sector that we have. And out-of-pocket financing and private insurance are the means for for kind of seeking access to the private sector. Private insurance basically for inpatient care. I mean, we don't have outpatient care insurance in this country. We don't have comprehensive insurance. And our out-of-pocket burden is estimated at about 5,300 rupees, 350 rupees per capita, which is about 750,000 crores. This is from the private consumption data that the NSS brings out every year. So this is what is the trend of the private health expenditure, and how much of that is insurance. So as I said, health insurance is gaining. I mean, they are also getting public resources to make profits out of. And today, the insurance market is probably close to 800 billion or 80,000 crores. In 21-22, it was 731 billion. And of which, in terms of rupee value, the government's investment is small. But in terms of the outreach through the PMJAY scheme and other state schemes, they're covering 30 crore population, 31 crore population. And then there's private group insurance and individual insurance. And you can see the individual insurance is the most expensive. On a per capita, per person basis, the average value of premium is nearly 6,000 rupees if you insure as an individual. And if you go age-wise, then as I mentioned, that if you're 25 years old, you're probably paying 3,000 or 4,000 rupees for that same amount of insurance cover. And if you're 50, 60 years old, then you're paying probably 10 times that amount. So then there's social insurance, and here it is here that we see the discrimination inequity that I talked about. Okay, so those who have access to any form of social insurance, whether it is the CGHS scheme or so if you look at the central government health scheme, a government employee, central government employee, a member of parliament who is representing us through our taxes, they're getting a benefit of 14,000 rupee per beneficiary. This includes the employee and their family members. Okay, so this is the kind of expenditure being incurred on then compared to 1,800 rupees per capita, which is the general health budget of this country. Okay, ESIC, organized sector workers, but these are organized sector workers at the lower end of the hierarchy. I mean, these are workers because there's a ceiling, income ceiling to become a member of ESIC. So people earning 21,000 rupees per month is the income ceiling. If you cross that limit, then you go out of the ESIC bracket. And we know today that 21,000 rupees per month is peanuts. I mean, it has very little meaning, even in the organized sector. The average organized sector salaries are probably much higher. Okay. And then you have the armed forces, another kind of beneficiary group, which is probably getting more than 15,000 rupees per beneficiary. Railways, other welfare funds are there, and so on. So access inequities are there because at one level, I said we have a private sector and you have segmentation of the population in accessing healthcare. So there are certain privileged groups within society on which our own tax money, it's not that people are paying out of pocket. Parliamentarians don't pay out of pocket. Okay, they get health cover for life even if they've ceased to be MLAs or MPs. Okay, and this is taxpayers' money which they're utilizing. They get 8 to 10 times more resources to for health to meet the health needs. Social health insurance, as I said, covers 8% of the population. Citizens are left to the mercy of the market. And and they have to bear a huge out-of-pocket burden over rupees 5,000 per capita. So this is some of the documents in which you can find the data that I have used. If you're looking for a data on health budgets, on health financing, on social insurance, on voluntary insurance, etc., these are some of the documents which will give you the data. Now, give me another 2 minutes and I'll wrap up. And now, why are budgets important? Is because we have not invested enough, and this is the evidence for that. These are deficits that we see in the public health system. Okay, if you want to overcome these deficits, then we have to at least move closer to 2.5 to 3% of GDP, which our own health policy talks about. Okay, even the 2017 health policy, which this government has tabled in Parliament, talks about 2.5% of GDP. Now we are far away from that. I mean, less than half, in fact. So we don't have demand-based planning in this country. That's the first deficit, because how do you decide what should be available to a primary health center or a district hospital? There has to be a bottom-up planning process, because health is best kind of planned in a decentralized manner, because needs differ across districts also. Okay, so we don't do that, despite the fact that we have a constitutional mandate for bottom-up planning, which is the district planning committees. The planning commission was not created by an act of law. Okay, so it was not a statutory body, but it was given a whole lot of resources to plan for the larger economy. The district planning committees are there. In health, you have the PIPs, the program implementation plans of the NRHM or the NHM now. But it doesn't happen. I mean, this is just some kind of paperwork is done, but there's no real planning happening by taking the community into account. We have a deficit of investment and expenditure, which we have seen. We have deficit of governance and implementation. It's a top-down decision-making process. I mean, what goes for primary health centers or for district hospitals is decided by the state capital or the national capital. So, and as a consequence, there's failure of governance and implementation that we see, because there is no kind of stakeholders owning the process at the level where delivery happens. There's deficit of accountability. Okay, no legislative oversight. I mean, we elect representatives to the assemblies of parliament, but we stop asking questions once they are. So we don't ask them questions, they don't question the executive. It becomes a cycle of lack of accountability. The CBMP, the community-based monitoring and planning process, was part of the NHM, but it failed miserably, except in Maharashtra, where for certain reasons it has continued even till today, but limited to about 18 districts. And that has really changed the healthcare, the rural healthcare system in these 18 districts, where demand has increased, where people put pressure on the district health office. If medicines are not available, if there's a shortage of supplies, they put pressure and they get them immediately. So that has created some sort of a demand-based pressure on the state system, and those then become the privileged districts and it has been working. And now this government wants to kind of get rid of that process also. Deficit of political will and executive commitment. I mean, our executives, people in the health ministry, I mean, they're not really working for the communities they're supposed to work for. And they will see that their own healthcare is assured rather than planning for the larger population. And there's deficit in policy. We are increasingly becoming market-driven, and we need to now reclaim healthcare as a public good. So I think it's very important to understand that health should be a public or a social good. It cannot be left to the market, to the whims of the market, because markets will create further inequities. Interestingly, before the 2017 policy was finalized, there was a draft 2015 policy on the basis of which the policy was further kind of developed. But unfortunately, the 2015 draft was an excellent draft. And since you have access to the presentation, I will not go through it. But it basically talked about what I have been talking earlier about having minimum 2.5% of GDP, at least 3,800 rupees per capita should be the budget, and so on and so forth. Uh, that free drugs should be available, free drugs and diagnostics should be available, follow Indian public health standards, and so on. But the 2017 policy completely changed the thing. Niti Aayog kind of pushed for privatization, for an insurance-based financing mechanism, and as a result, the Ayushman Bharat policy evolved, whereby you had an insurance-based system for hospitalization and health and wellness centers to kind of strengthen primary healthcare, which conceptually is quite good, the health and wellness center concept. But very few states have been able to implement it in a very significant manner. Kerala has done quite a good job. They call them family health centers, which they have been implementing. Chhattisgarh has also, in many of the districts, they've been able to strengthen healthcare at that 5,000 population level. And of course, now the emphasis is more on insurance-based financing and dilution of tax-based financing. This is what. So if you look at the proportion of public spending, it's going down. Actually, we're somewhere around 4% of government budgets being allocated to the health sector. And they also want to privatize social insurance. Like they want to take over CGHS. It's already privatized because in CGHS, I mean, people don't go to AIMS or Safdarjung. They go to escorts and again, there's a different category. There's a kind of inequitable categorization of who accesses what. So there are the limits which have been specified for secretarial level staff, the secretaries and joint secretaries, and for the clerical staff are different. So there's discrimination within that kind of an inequitable scenario. And so this is what I mean. The entire healthcare system, which is being destroyed gradually, and kind of there's been a move towards a more private sector dominated economy. And health insurance won't work. I mean, if you're going the health insurance way, it's not worked anywhere in the world, including the US, which is the mecca of health insurance. And we see in the US also there is at least 35 to 40 million population which doesn't have access to healthcare. So it's and in India, especially with an unregulated healthcare environment, I mean, there's a huge amount of fraud that happens in the name of insurance, and it favors the rich and promotes further inequity and elitism. Similarly, Ayushman Bharat, which was largely based on insurance, and now, I mean, they've realized that insurance doesn't work that well, so they're moving to what is called the trust model or a mixed model. So that is what is happening with Ayushman Bharat, and we see that it really is not working, because if you see the utilization of the limited resources which are also given for Ayushman Bharat, the utilization is very poor. They don't even utilize 50% of the funds. So finally, I mean, in terms of advocacy, I think we need to kind of strengthen the social insurance models like ESIC and CGHS, which should be available to everybody. So why shouldn't every Indian citizen get the same kind of healthcare which CGHS provides to its employees and members of parliament? Universalize ESIC. So all workers, why only a certain proportion of workers? All workers should have access to ESIC and create a kind of a common system. But the moment you have a segmented system, it becomes discriminatory in nature. And so if you kind of create a strong social insurance system, I think, and then universalize it, I think at least 60 to 70% of the population can be covered under that. And that will also, because it's usually a contributory system, so you can raise at least 1.5 to 2% of GDP additionally for healthcare through that process. And this is the final slide. health system needs to be organized and brought under a single umbrella. I mean, we treat private public sector differently, but I think we cannot do away with the private sector in this country because it's too huge. So we have to see how we can socialize the private sector by kind of reining in the private sector to work for social health goals. Okay, health provision prices have to be regulated. In the private sector, I mean, they charge everything. We saw in COVID what happened with the private sector charges. So there has to be very strong. Though the Clinical Establishment Act is there in some way, many states have not yet implemented it. But all states, there have been struggles, and IMA has kind of opposed it, especially for price regulation. They don't want any price regulation. And public spending, of course, needs to be increased to 3% of GDP at least, or 5,000 rupees per capita, as we saw in select states. And so we need, finally, we need a political will to actually change our healthcare system. So we will not realize 3% of GDP for health unless there's a political will backing that, which Thailand has done, and Brazil and many other countries are increasingly doing that. Thank you.
Thanks, Ravi, for excellent presentation. Now it's thrown open to questions from the floor. I can't see any. No, talking to the mic, they go online. There were 29 people attending online.
Thank you. It was really thought-provoking. I was just wondering, you said you require political will to bring up that health expenditure to forget about 3%, even a little bit more to 2 perhaps. But why is there no political will even today?
Okay, I'll give you one example where, I mean, some political will has been expressed. That's the state of Rajasthan. You remember that last year they passed this legislation on this year, in fact, on right to health. But there was a history behind that. There was 4 years of the Jan Swasthya Abhiyan pushing to create that political will. So they began with free drugs and diagnostics as a first step in all public institutions, and they built that. The Rajasthan followed the Tamil Nadu model of for procuring drugs, which provided them more resources and more drugs available with fewer resources. So those kind of initiatives were a 3 or 4 year period, and then this year, of course, they probably did it because elections were coming. But nevertheless, it's the first step that they have taken. In fact, I did an edit piece for the EPW on this, and I said, can Rajasthan be India's Saskatoon? The Saskatoon was the Canadian province which began the process of creating right to health in Canada, okay, way back in the 50s. So that's the first step. And I think now many other states, especially southern states, are trying to kind of emulate Rajasthan by trying to bring in the debates happening in Tamil Nadu, in Orissa, to kind of bring in legislation for right to health. So political will has to be created. Elections have to be fought on the issue of healthcare.
So, Ravi, I mean, what you mentioned about political will, if I see in the context of Thailand's model, where they said this that a triangle that moves a mountain, they did consider political will at one level, but even if when they did it exactly, when this opposition was campaigning for election, and they won the election on this ground. The second thing they considered, which was very important, was the people's demand for it. And I think there
was pressure from below.
There is still also, forget about someone's largest, someone, a benevolent dictator doing it or somehow. But I would see that this is a major problem, that there is actually no demand for anything beyond, for certain medical services in terms of, healthcare or whatever.
Yeah, because we have our mentality has been developed like the American mentality, that healthcare is an individual problem, it's not a collective problem. And therefore you see, I mean, Ritu Priya in the morning did refer to that when she gave the example of the US, which spends about 20% of its GDP on healthcare. And on the other side, you have Cuba, which spends only 6% of its GDP on healthcare, and they have better health outcomes than the US. They spend probably 10 to 15 times less than what the US spends per capita on healthcare. But yet Cuba has much better results. Canada spends only 8% of GDP. It is much better, much better than the US in terms of healthcare access as well as outcomes.
Well, the point I'm trying to making was it's not the political will alone that is going to get this.
Yeah, political will comes to public pressure.
So that besides that, the pressure has to be there. It's not just the largest of someone's political will.
And in Thailand, it's a continuous process. It's not stopped still. I mean, the assemblies are held all over the country. And for instance, about a year or 2 years back, there was a huge wait list for dialysis. I mean, they pushed the government hard, and now they have dialysis centers all over, and the wait lists have gone down.
So this is sort of almost a naive question. So if we had to invest, let's say most of the developed countries invest at least 6 to 10% of their GDP into health. And if we had to do this, where would the money come from?
Okay, good question. I don't think we have a paucity of resources. It's a question of priorities, where we are putting the money, or where we are kind of, we have a tax GDP ratio of only 16%. Okay, whereas most countries which provide good social security have a tax GDP ratio of 25 to 30%. So there's a huge gap. Now, how do you fill that gap? One is that at least 7% of our GDP goes into rebates to the corporate sector. What in India we call as revenues foregone. So all those rebates that they're given, why? So that 7% is enough additionally to help health and education in the country. And the tax arrears, you know what are the tax arrears in this country? It's a cumulative total of something like 12 lakh crores, which is half the total taxes the government collects. Okay, so and every year that increases. Now that itself is another 6% of the GDP. So if our tax discipline improves, okay, and all those areas which are there are collected on time, etc., I think we can get the resources. If we cover the entire workforce and create a social insurance system. Okay, today, I mean, we're covering only 8% of the workforce. So all the workers, if not all, at least say 60% of the workforce is covered. We can generate more resources. I mean, just to give you an example, if Mukesh Ambani is part of the ESIC scheme, the contribution that he will make will be much higher because it's a proportion of your salary. Okay, so right now the total contribution is 3.75% of wages. It was reduced actually; it used to be 4.5. So his 3.75% from his wages would be a huge amount. Okay, so if all the workers are covered, the managerial staff, etc., you will raise another 2-3% of GDP for health.
No, unfortunately, I'm under severe pressure. I'm going to ask the last question, but unfortunately, this will have to be 3 questions in 9+. Please answer them on the Discord or somewhere where everybody can read the answers. So the question I'm giving you, but I don't think you can give the answer. Has Ayushman Bharat decreased catastrophic health expenditure for the poor? And has it increased, has Ayushman Bharat increased the access to tertiary care? Last question, but I don't think they'll let you answer.
Access has increased, but not out of pocket has in fact gone up. And states which spend more on Ayushman Bharat kind of scheme, they actually out of pocket expenditure has gone up according to the government's own data, NSS data. Okay, thank you.
I invite Dr. Prabir Chatterjee to present a memento to Mr. Ravi Duggal.